Hello, I'm Dr. Rita Dellastritto, and today I'm going to present to you 12 lead EKGs, down and dirty. I'm hopefully going to teach you just some really simple ways to look at a 12 lead EKG and figure out what's going on, especially looking for MIs and bundle branch blocks and that sort of thing. But before we go into 12 lead EKGs, the first thing that we need to understand is the conduction system. So here's the conduction system. And you need to remember that when we're looking at a 12 lead EKG, what we're looking at is the electrical pathway. Nothing more, nothing less. And by looking at the electrical pathway and how long it takes for electricity to move throughout the heart can give us an idea of what might be going on. So when we look here at the cardiac conduction system, we need to remember that the cardiac conduction starts at the SA node, which is up here. So here's our SA node, and then it follows on down through down to the AV node, and from the AV node we go down into our bundles of His and our Purkinje fibers, etc., etc., etc. And here's our AV node, or our junction, which is sometimes what it's referred to. And then if you see, we have our left bundle and then our right bundle. And so as long as you understand that really the pathways and how things move, you can kind of understand the rest of it. So here is basically what an EKG complex looks like in a rhythm strip. This should all be basic understanding. So if you remember, height is voltage and time is across the bottom. So as we move from left to right, that's time in seconds. Remember, each little square box is 0.4 seconds, and then after that, you 5 of them make 0.2 seconds, etc., etc. So time and voltage. And then when we look at our PQRST, this is just our normal complex, and that's all I really want to show you here. Sometimes you have a U wave, which can be pathologic also. But for right now, all I really need you to understand is the rhythm, the paper, and what the PQRS complex looks like. So what I want you to look at here is the 12 lead placement. And when we talk about 12 leads, it doesn't really mean 12 wires. If you'll count the red wires, you'll notice that there's only 9 wires, but we do a 12 lead EKG. And that's because the limb leads, the right leg, the right arm, the left leg, serve more than one purpose, whereas the chest leads, V1 through V6, serve only one purpose. The limb leads are bipolar leads. In other words, you need 2 poles. You need a positive pole and a negative pole, whereas the chest leads are only 1 pole, and they're generally a positive pole. Well, generally all the time. So as I said before here, the chest leads are V1 through V6, and our limb leads are RA, which is right arm, LA, left arm, LL, left leg. The RL, or the right leg, is just basically a ground wire. It really does not serve any purposes in a 12 lead EKG, but sometimes I think they do it just for symmetrical purposes. But sometimes by not having that right leg there, you can have some interference or kind of static in there. So they use the right leg lead as a ground. So now what I want you to look at here is our 12 lead EKG. This is a normal, pretty typical looking 12 lead EKG. As you can see by looking at this, we have kind of in order here. Let me pull up my pen. We have lead 1, lead 2. Okay, what I want you to notice about these, and lead 3. Here we go. So what do I want you to notice? Well, lead 1, 2, and 3 are Roman numerals, and then when we talk about the V leads, we've got V1 and V2. Notice how V2 is a numeric number. It's not a Roman numeral number. So when we take those off, get those out of the way. So when we're talking about lead 1, try not to get lead 1 confused with V1. And so remember I said earlier that we have limb leads and we have chest leads. Limb leads are bipolar, chest leads are unipolar. And so if we divide our EKG from the Roman numerals to the regular looking numbers, then we can figure out where our limb leads are versus our chest leads. So chest leads always start with a V, V1, V2, V3, V4, V5, V6. The limb leads are 1, 2, 3, AVR, which means augmented vector right, AVL, augmented vector left, AVF, augmented vector inferior, or foot, however you want to remember it, whatever works for you. So we have our limb leads on one side and our chest leads on the other side. So when we look at the Ivanhoe triangle here, this is kind of to give you an idea of what's where on when you're looking at the leads. So right now we're looking at the limb leads here. And what I want you to look at is, if you'll notice over here on the right, and if you'll notice right here, our right arm, you'll see that it says negative in this spot and negative in this spot. What that generally means is those are negative poles. They don't have any positive polarity at all on them. When we look at the left arm, we'll see that it's got a positive pole and a negative pole. And when we look at the left leg, we notice that it has 2 positive poles. Now remember I said that limb leads are bipolar. It has to have a negative pole and a positive pole. So when we look at lead 1, which goes from the right arm to the left arm, we notice that the right arm is a negative pole because it always is negative, and the left arm is a positive pole. All right. When we look at lead 2, it goes from the right arm to the left leg. Now, remember, the right arm is always negative and the left leg is always positive. So this is the positive pole. When we look at limb lead 3, we go from the negative left arm to the positive left leg. So the only one that switches polarity depending on which lead you're looking at is the left arm. The left arm can be positive or it can be negative. The right arm is always negative, the left leg is always positive. So the left arm can be either or. Now why is that important? Well, it's important for understanding the direction that the electricity moves in. So if the electricity moves toward the positive pole, we like to say that we get an upward deflection. All right, so now what do we see here? What we're basically looking at right here is the augmented vector right, augmented vector left, and the augmented vector inferior or foot. The thing about the augmented vector leads is that they are unipolar, meaning that there's only one pole. Remember when we had the limb leads, we talked about that they could be either bipolar or unipolar. If they were bipolar, they had a negative lead and a positive lead. Well, in this case, we have unipolar leads, so they're positive leads. So when I talk about positive leads, I like to think about the positive lead being a camera. And so here I have my augmented vector right camera looking at the pathway of the electricity. So if we remember correctly, that our electricity in the heart travels basically in one direction, from the SA node down to the bottom of the ventricles, and then it kind of loops back around to help with contraction. So if you remember the direction that electricity is supposed to travel, then you can imagine looking through the lens of a camera as to what the the QRS complex should do. So if you're looking through the lens of a camera and somebody is moving away from you, the subject becomes smaller. If they're moving toward the camera, the subject becomes bigger. Well, so if the positive lead is the camera, and we know that electricity is moving away from the camera, then we should get a negative QRS complex. So if the electricity is moving away, it's going to drop below the isoelectric line. And if we remember, let me get my pointer where I need it. This is the isoelectric line. And so the negative QRS complex means that the electricity is moving away from the positive lead, or like I like to think about it, is away from the camera. So if we go over to the left side, we put our camera over here. Our AVL is also a positive lead because it is a unipolar lead. And if we remember the direction that electricity travels down, kind of travels across. If you remember looking at the very first picture, you saw electricity traveling across the heart also. And so because electricity is traveling kind of generally in that direction, kind of where it spreads out, it's heading toward the camera. The same thing with the augmented vector F from the foot. Electricity is traveling directly toward the camera. So what are we going to see in an augmented vector foot and augmented vector left is that we're going to see a positive deflection of the QRS complex because it's coming closer, so it's getting bigger. And in terms of the rhythm strip, here's our isoelectric line. The majority of amplitude is going to be above it. So if it's traveling away from the positive lead, or the positive lead being the camera, we get a negative deflection. If it's traveling toward the camera or the positive lead, we get a positive deflection. It really is as simple as that. So now let's look at the limb leads. If you remember, the limb leads are bipolar, so we have a positive side and a negative side. AVR is always, the right arm is always negative unless it's AVR that you're looking at. So lead 1 goes from a negative lead to a positive lead. So if it's going from a negative lead to a positive lead, we put our camera at the positive lead. We know that electricity is flowing in this direction. And so we know that we should have a positive deflection on our QRS complex. Lead 2 and lead 3 all head toward the inferior lead, or the left leg, because those are the positives, so we stick our camera there, and we know that the electricity is always traveling towards the positive lead. In this case, we want, generally, the electricity should be traveling toward the camera, and if it does that, then of course we have a positive deflection in our QRS complexes. So in normal looking 12 lead EKGs, and you can go back and look at a normal 12 lead EKG, we should have a positive deflection in lead 1, a positive deflection in lead 2, and a positive deflection in lead 3. And then we go to the augmented vector leads. Augmented vector left should look very much like lead 1, because in lead 1, AVL is also the positive lead. So AVL is positive in the AVL lead. Lead 1 is positive. The left arm is positive also. So the electricity is traveling toward a positive lead, so we should always have an upward deflection of our QRS complex. The same thing with lead 2. Lead 2, the positive lead is at the leg, and so we know that electricity travels toward that left leg lead, so we should have a positive deflection. We also know that lead 3 travels toward the foot. So lead 2 and AVF should look very similar. Lead 2, 3, and AVF should look very similar to one another. And then AVR is the only one that is positive when we're in the AVR lead, but the right arm is always negative. So when we're looking at the lead 1, 2, and 3, the only purpose for the right arm is to have that negative part of the bipolar deflection. But when it becomes AVR, it becomes a positive lead. And a positive lead, the electricity is moving away from it, so AVR should always be a negative deflection. Now, that is the first lead that I look at when I look at a 12-lead EKG, because if AVR has a positive deflection, it tells me one of two things. There's probably, and this is the most likely thing, is there's probably flipped limb leads. So in other words, instead of the white lead being on the right arm and the black lead being on the left arm, they were probably changed. And now we've got the black lead on the right arm and the white lead on the left arm. That's why I always, because I work in an ER, I always ask them to leave the rhythm strips, the limb leads on, so that I can look at it. I always ask them to leave all the leads on so I can look at it, especially if the EKG looks funny. If it looks normal, I say, okay, you can take them off. If they look funny to me for some reason, I go in and I take a look at it. So if AVR is positive in deflection, think limb lead transposition. They put it on the wrong side. The other thing is it could be that there's a defect in the electrical activity. Something is making that electricity reroute and come back the other way. In that case, they probably have a 12-lead EKG that shows that previously. But always, always, always look at AVR first. If it's not a negative deflection, you need to question whether or not those leads were put on correctly, because you got a bad EKG. So placing of the limb leads, the chest leads. So we have V1 through V6. And the easiest way for me to remember is that the V1 lead goes, here's our first space, second space, third space, fourth space. So the fourth intercostal space on the left goes the first one. Some people say the fifth rib, I just do the fourth intercostal space. Goes the first lead, V1, on the right side of the sternum. V2 goes on the left side of the sternum, on the very same space. The next one that I put on is V4. And why do I put on V4? Well, because after putting on V4 at midline at the fifth intercostal space, I go back and I put V3 in. So V3 goes halfway between 2 and 4. So you have to put on 2 and 4 first, and then you go back and put 3. V5 goes on the anterior axillary at the fifth intercostal space, and V6 goes at the mid-axillary at the fifth intercostal space. So you're getting a true picture all the way around the heart. So here, what I'm showing you is basically, remember that the chest leads are a positive vector. And so if it's a positive lead, it looks at electricity coming at it and going away from it. So if you think about V1, which would be right here, V1, so you would say that V1 has most of the electricity going away from it. So V1 should be negative, right? V2 has a little bit of electricity coming at it, but the majority of the electricity is going away from it. So V2 on an EKG might have a little upward spike, and then the majority of the QRS complex is going to be downward. By V3, it may be biphasic, where part of it's going up and part of it's going down. But by the time you get to V4, that's at the base of the ventricle, you have all the electricity coming toward that lead. And so it should be completely in the upright position. The QRS should be going positive all the way up. And then V5 and V6, again, will have positive deflections of the QRS. It may be lower amplitude than V4, but they should all be positive. Now, one of the things that I like to do is a way for me to remember which leads have to do with which portion of the heart is to remember Sal. And Sal I'm from New York State, so Sal is a mule who pulled the barge on the Erie Canal. So that's how I remember it. So Sal, septal, anterior, and lateral. So if you think about this, this is the septal portion of the heart, V1 and V2. V3 and V4 are the anterior portion of the heart, and V5 and V6 are the lateral portions of the heart. If you know the Erie Canal song, I had a mule, her name was Sal, 15 miles on the Erie Canal. That's how I remember it. And don't ask me why, that's the way my mind works sometimes. But V1 and V2 look at the septal lead, or the septal portion of the heart. V3 and 4 look at the anterior portion of the heart, and V5 and 6 look at the lateral portion of the heart. So, if we think about it, go back and think about where our lead placements are. We have lead 1, which goes across the top from the right atrium, from the right arm to the left arm. So we have lead 1, which goes across the top. Lead 1 goes from the right arm to the left arm. Left arm being the camera because that's the positive side, so we're going to have a positive deflection. The other one that uses the left arm as a positive deflection is AVL. So those are your lateral leads. Some people call them the high lateral leads. They're right there. Okay? The other lateral leads, if we remember, are V5 and V6. So if we have a problem with in the lateral portion of the heart, we should see changes in 1, AVL, V5, and V6. Then our inferior leads are 2, 3, and AVF. Think about where that camera was when we were looking at the camera for lead 2 and lead 3. The left leg is positive always, and in AVF the left leg is positive. So those should all look very similar, and if you look at this, they all look very similar. The other thing is, look at this shape right here. I like to think of this as a boot. It kind of looks like a boot shape, doesn't it? And what we say in the ER is when we have ST elevation in the boot, we need to boot them out of the ER to the cath lab or to the ICU. And then we look at the V leads, the vector lead. I'm sorry, let's look at AVR first. Notice that AVR is a downward deflection. Okay? And remember what I said before, the only time AVR, or the right arm, is positive is when you're looking at the augmented vector leads. So it should be a negative deflection because all the electricity is moving away from the camera. So now we look at the septal leads. So you notice the checkerboard or the dotted line that goes around V1 and V2. So V1 and V2, they're both septal, but V2 can also be part of the anterior portion of the heart also. That's why V2 is kind of surrounded by a green line and a dotted line. But most people think of V1 and V2 as being primarily septal lead problems. So if you see changes in V1, you should see changes in V2, meaning that it's a septal wall injury. If you see changes in V3 and V4, but you don't see any changes in V1, and maybe a little bit of change in V2, then we're dealing with an anterior injury. If you see ST elevation in V1, 2, 3, and 4, then you have a septal anterior wall or anterior septal wall MI, however you want to determine it. And then V5 and V6 are lateral. I would learn this chart if I were you, because it comes in very handy when you're looking at the heart, or you're looking at the 12-lead EKG and you're imagining which part of the heart it's coming from. So our lateral leads are 1, AVL, L being lateral, and then V5 and V6. Our inferior leads are all the limb leads, 2, 3, and AVF, foot or AV inferior. And then septal V1 and 2, anterior V3 and V4, and lateral again is V5 and V6. Now, why is AVR not counted for anything? Well, the only real purpose for AVR, I think, is in my own little brain, I'm going to say this, is that AVR is really used for lead placement. And so if you have a positive deflection in that AVR, again, you need to think that the leads are placed wrong. I also think that AVR is there because without it, you'd have an 11-lead EKG. And we don't want an asymmetrical 12-lead EKG. So that is a little bit of humor. I know, bad humor, but AVR, though, is the very first lead that I generally look at to make sure we have correct lead placement. So this is ST elevation. As you can see here, here's our isoelectric line, and we have elevation of that ST segment. That usually indicates that there's an acute injury going on. Or STEMI, ST elevation MI. That's what our STEMIs are, what they look like. Then we have ST depression. That generally indicates that there's ischemia that has occurred. So if you look here, this being our isoelectric line, we can see that our ST segment is dropped below our isoelectric line. And then when they've had a previous MI or some sort of damage that's been done, they'll get an inversion of their T wave. They have a normal P, QRS, and then our T is depressed. So that's T wave inversion. That usually means somewhere along the line they've had a previous MI. And then there's a thing called a Q wave. And a Q wave is 0.04 seconds wide, or at least 1/3 the height of the R wave. So 1/3 the size of the R wave. And it can take 8 to 48 hours to show up on an EKG, and that usually indicates that somebody's had an MI, and it never goes away. So it may get smaller, but you'll always have a Q wave there if somebody's had an MI. So here is a Q wave MI. And so if you look closely, first thing I look at is AVR. Is my AVR positive or negative? Well, as we can see by this, it's negative. So I'm good to go. Let's look at the rest of it. So we look here, and you see that little dip before the QRS complex, especially in our inferior leads. Our inferior leads being 2, 3, and AVF. And you can see that little dip. That's our Q waves that are occurring there. So 2, 3, AVF are our inferior leads. Notice we don't see them anywhere else. So we can say for sure that we've had an inferior MI somewhere in the past. Or the person could be having a Q wave MI now that has just not been seen, or that just not has evolved into an ST elevation yet. So here's the evolution of an MI. So you start out with number A, it's normal prior to the MI, and then B, we get that hyperacute or that ST elevation, the Q wave starts to elevate, the T wave starts to elevate a little bit, and it gets bigger. And then in the next step is the C, where the ST elevation is way up there, and we get that hyperacute look to it. And some people refer to that look as a tombstone, because it kind of looks like a tombstone when you look at it. And then the next step is D, where we get that pathologic Q wave, and then our ST elevation starts to come down, and our T wave decides that it wants to try and start everting. And then E, we still have that pathologic Q wave, and we've got total T wave inversion now. And then by F, we've got Q wave, and then when we start getting fibrosis, we start getting more of an upward T wave again. So flip T waves generally mean that they've had a MI within the recent past. When it has returned to normal position or normal upright position, it usually indicates that they've got the fibrosis that have occurred in the area. But notice how that Q wave, once it forms, it never goes away. So let's take a look at this, and I want you to tell me where the elevation of the ST elevations are. So first off, again, look at the AVR. Now I systematically look at this. So I first look at AVR. It's a negative deflection, so we're good to go. And then I look at my lateral leads, because why not? 1 is right there. So look at 1 in AVL. Okay, so AVL looks a little bit different than 1. Then I come over and look at V5 and V6, and it looks pretty much like 1, so I'm not too worried, except we got a little bit of a downward deflection or Q wave, maybe a little bit in V5 and V6, but that's okay. Then I look at 2, 3, and AVF, and what do I notice? I notice that I'm starting to get an elevation of the ST segments right here. This is my ST elevation. And so to me, that's indicating that I have some sort of MI or something going on. And notice where it is. It's in my boot. So I'm going to boot this person out. This person needs intervention because they're having an inferior wall MI. So, did you guess inferior? Okay. How about in this one? So again, AVR, I've got a negative deflection, which is what I'm looking for. 1 in AVL. I know your eyes are automatically going over to the limb leads or the chest lead side, but that's okay. Let's do it systematically anyways. 1 in AVL look fine, 2, 3 in AVF look okay. Then I come over here and I'm going, holy schmoly, look at V1, V2, V3, V4, a little bit of V5. So what leads are elevated? V6 is normal, so I can probably, since I have a normal 1, an AVL, and a normal V6, my slight ST elevation in V5 has nothing to do with my lateral leads, because I need 2 or more consecutive leads to have elevation. And I only have slight elevation in V5, but none of my other lateral leads. So I can't say that I have a lateral lead infarct. But I sure can say that I have ST elevation in 1, 2, 3, and V4. So V1, 2, 3, and V4 are all elevated. And remember, V1 and V2 are my septal leads, and V3 and V4 are my anterior leads. So I have an anterior septal MI, or STEMI, because I have a ST elevation. You can call it septal anterior, but most people, for whatever reason, call it an anterior septal. All right, let's look at this one. So it's a little wiggly, but let's look at let's look at AVR first. AVR is normal. It's the way we want to see it. But what's going on with 1 and AVL? When we look at 1 and AVL, that we look like we have ST depression going on. So let's look at V5 and V6, because it's part of the lateral leads. We see something wrong over here in 1 and AVL. So let's go over V5 and V6 and look at that. Those look normal. All right, so we've got something going on either high lateral, or high lateral basically. And then now let's look at 2, 3 and AVF. Man, we got ST elevation in 2, 3 and AVF. So we know that 2, 3 and AVF are our inferior leads, and we know that 1 and AVL are our high lateral leads. But why do I have ST elevation in 2, 3 and AVF, but I have ST depression in 1 and AVL. And that's because I have an acute MI occurring, an acute ST elevation or STEMI in the inferior leads, 2, 3, and AVF, but I have reciprocal changes or changes on the opposite side, kind of like a mirror change in the high lateral leads. So 1 and AVL are depressed, and we call those reciprocal changes. So let's go through here and look at V1, V2, V3, V4, V5. Now, what did you notice about V1, V2, V3, V4, and V5? Notice that we don't start getting the we should be getting a positive progression of our QRS complex, but notice in V1, it stays downward. V2, it stays downward. V3, it stays downward. V4, it's still downward. It's not until we get to V5 and V6 that we get an upward deflection of our QRS complex. And we call that a poor R wave progression. So this person's probably got a badly diseased heart anyways. And we notice here we've got some ST depression a little bit here and flip T waves here. So this person has probably had an MI in the past. We got flip T wave, flip T wave, flip T wave, flip T wave. Lord only knows where that T wave is, but it's kind of flattened out, and we've got a little bit of a T wave here that doesn't look that impressive. So I would be guessing that this person has probably had previous MIs. But so we have an inferior wall MI with lateral reciprocal changes and poor R wave progression. If we do not have a positive deflection of that QRS complex by V4, it's not totally positive. We call that a poor R wave progression. So now let's talk about axis deviation. What's the difference between a right axis and a left axis? Does it really matter? And does it mean anything? Well, an axis is the average direction of electrical activity during ventricular depolarization. Okay, how do you explain that? I'm not going to explain this. I'm going to explain it a different way. So let's first talk about what does it mean. So the QRS axis is going to shift basically due to the position of the heart or the size of the heart, or if there's a conduction block of some sort. So tall, skinny people, think about it, imagine a tall, skinny person, their heart is going to kind of drop down a little bit, whereas a pregnant person or an obese person, their abdomen is going to push up into their chest and maybe push their heart over to a different axis. And then, of course, a conduction block changes the way that the electrical activity travels, so that produces an axis change. So right axis is normal in children and tall, thin people. Now think about it. If you're tall and skinny, then your heart kind of drops down a little bit more and kind of shifts to the right. So when we're looking at your EKG, we might see a little bit of a right axis deviation with right ventricular hypertrophy. So the right ventricle gets bigger, so you're going to have more electricity on that right side because it has to travel further. Chronic lung disease, anterior lateral myocardial infarctions in the past will give you a right axis deviation. Left posterior hemiblock, pulmonary embolisms, Wolff-Parkinson's White syndrome, atrial septal defects, ventricular septal defects. I mean, there's loads of things that can cause a right axis deviation. Left axis deviation, kind of the same thing. Left anterior hemiblock, Q waves of inferior myocardial infarctions. Artificial pacemakers give you a left axis deviation. Emphysema, patients with emphysema often have a left axis deviation. Hyperkalemia, Wolff-Parkinson White, tricuspid issues, etc., etc., etc. So then we have this thing called a northwest deviation or no man's land. So it's not going left, it's not normal, it's not going right, it's going way off in some other direction. And that's usually due to like pacemakers or lead transposition. Again, that leads aren't in the right place. That's why it's always important to look at AVR. Emphysema, but a lot of times you'll see it in patients with hyperkalemia. The most common place that I usually see it is pacemakers, lead transposition, and hyperkalemia. So we're going to let our fingers do the walking and do the talking and figure out what axis deviation, because don't make me count boxes and figure it out by that little star pattern that we saw at the beginning of this side, because I can't do it, but I can let my fingers do the. Now we're going to look at a 12 lead EKG here and look at the axis deviation. So the first thing I want to do is find a inferior lead and a lateral lead. And so we basically look at our limb leads. Lead 1 is our lateral lead, and lead AVF is an inferior lead. Now I could pick anyone. I could pick 1 or AVL if I wanted to, or I could pick 2, 3, or AVF for my inferior leads. But to make life easy and to do this, I will pick a lateral lead as 1 and my inferior lead as AVF. So the first thing I want to do is look at AVR. Is AVR a downward deflection? If AVR has a downward deflection, then I know I'm good to go. I don't have to worry about transposition of the leads. So now I can really determine whether or not I have an axis deviation. So let's look at lead 1 and see what direction it's going in. So with my left hand, my left index finger, I put my finger on that lead and show what direction it's going in. So it is going in the upward direction. So my left finger is pointed up. Now let's go down to my inferior lead, AVF, and see what direction that's going in. So here's AVF, and I also notice that it is going in the upward direction. So I take my right finger and I put it on there to see what direction that is going in. And sure enough, it's going upwards. So both fingers are going up. If both fingers are going up, I have a normal axis deviation. Okay, so if the QRS complex is going up in both of those, I have a normal axis deviation. So both fingers up. I was studying to learn how to do 12 lead EKGs many years ago, and I could not figure out axis deviation, and I almost quit NP school because I could not figure out how to remember it. And then I just accidentally figured it out using my fingers. It was just purely accidental. I've taught this to hundreds and hundreds and hundreds of people on how to do this. And so it works every single time. So normal axis deviation, both are going upward. So here we go. AVR is normal. Lead 1 is going up. AVF is going up. So my lateral lead 1 is going up. My inferior AVF is going up. So I have normal axis deviation. Both fingers are pointed up. All right, for right axis, let's look at AVR. AVR is going down. We're not going to worry about the fact that this looks like a junctional rhythm or anything like that. I'm just more concerned about the axis deviation at this moment in time. So look at lead 1, and the axis is going down, and look at AVF and know that it's going up. Now ask yourself, which finger is pointed upward? So if your left finger is pointed down and your right finger is pointed up, that's telling you you have a right axis deviation. So in a normal axis, both fingers are pointing up. In a right axis deviation, only the right finger is pointing up. So left finger is down, the right finger is up. You have a right axis deviation. In a left axis deviation, let's again first look at AVR. AVR is going down. I don't care about what else is going on in this rhythms in this EKG. We're only focusing on the axis deviation at this moment. So we find lead 1, and we see in lead 1 that the QRS deflection is going up. And then we look at our inferior lead AVF, and we notice that it is going down. So looking again at which finger is up and which finger is down, we notice that our left finger is pointed upward. So we have a left axis deviation. So our left finger is up, our right finger is down. We have a left axis deviation. Whichever finger is pointing up is the axis deviation. So if you have both fingers going up, you have a normal axis. But if your left finger is going up and your right finger is going down, you have a left axis deviation. If your right finger is going up and your left finger is going down, then you have a right axis deviation. But what about no man's land? Again, we're not going to worry about this, but when we first look at this thing, we see that there's an AVR is in the positive direction. So we need to be concerned is, did we get transposition of the leads? And in this case, we didn't, because we have a bundle branch block going on. And so because we have a bundle branch block, we have a right bundle branch, and we're going to talk about that in a minute. Our AVR could be going upward as kind of a normal situation. So let's look at 1, and it is going downward. Now let's look at AVF, and it is going downward. So both fingers are going downward, so we have no fingers pointing up. So because of that, we can say this is a no man's land or northwest deviation, because neither finger is going up. That is not normal, and so we call it no man's land. It's pointing nowhere. All right, now let's try this one without me putting any fingers up here. So again, first thing is look at AVR. Now in this one, AVR does go up. So it could be that the leads are transposed, but for all sakes and purposes that we want to look at, let's just go with the fact that this is normal for this patient. If I was to see that, I would go in and make sure that the leads didn't get transposed. But let's just go along with it and say that this is normal for this particular patient. So lead 1, which way is it going? Okay. AVF, which way is it going? So the QRS complex in lead 1 is going down. The AVF, the QRS complex, is going up. Which finger do you have up? Hopefully it's your right index finger that's pointing upward and not your left one. So your right index finger is pointing up. Your left index finger is pointing down, so you have a right axis deviation. All right, I'm not going to say anything for the next one. You figure it out. Okay, so AVR we looked at first. It looks normal. Lead 1, it is going upward, so our left index finger is pointed up. In AVF, I know what you're saying. Well, some of it goes up and some of it goes down. Well, where's most of the velocity going? The majority of the velocity or the terminal forces are going downward. So we'll call this a downward deflection. So AVF is down. So our right index finger is pointing down. Our left index finger is pointing up. So we have a left axis deviation. Were you right? Let's try again. Okay, so AVR is going down. Lead 1 is going up. AVF is going up. Both fingers are pointing up. So that indicates that we have a normal axis deviation. I hope you were right. All right, now let's talk about ventricular hypertrophy. Let's talk about left ventricular hypertrophy first. Notice that big muscle mass in this picture. Remember, electricity has to travel through all of that muscle mass, so that's going to increase the amplitude of our terminal forces in our QRS complexes. So there's a way of calculating this, and it's the Sokolow-Lyon index. And so what you do, and it sounds complicated, but it really isn't that complicated. So you look at the S in V1 and you add that to the R in V5 or V6, whichever one is larger, and you add those together, and if you come up with greater than 35 millimeters, then you have a left ventricular hypertrophy. But you also have to look at the R in the AVL lead to see if it's greater than 11 millimeters. So I know it's kind of complicated. It's kind of one of those things you got to learn, but this is going to help you to determine whether or not you've got a left ventricular hypertrophy. So remember, amplitude or the terminal forces go up or down. So each little tiny box that you're looking at is 1 millimeter. So each little tiny square box, and as you go up, you increase. So one big box, one big square going upward is 5 millimeters. So keep that in mind when we're looking at how to measure. So let's look at left ventricular hypertrophy and what it looks like on a 12-lead EKG. So the first thing we want to do based on the formula is look at the S in V1. And so if we count those big boxes, we can see that from the bottom to the top there, that we have approximately 5, 10, 15, approximately 20 millimeters. So we look at V1, and then we look at the R wave in V5 or V6. Generally, V5 is bigger. And again, if we count that, it comes out to be about 17 boxes. So V1 is about 20 millimeters. In V5, it's approximately 15 millimeters, so that equals 35. So let's go over to AVL and just make sure that AVL is at least greater than or equal to 11 boxes. And when we come over here and look, it's pretty evident that you don't even have to really count it out, because look how long that AVL is. So AVL is huge. It's greater than 11 millimeters. So we can say for sure that we have a left ventricular hypertrophy. Now let's look at the right ventricular hypertrophy. Remember, the right ventricle is a lot smaller than the left ventricle, so we're going to have smaller changes in amplitude. And also it's on the opposite side of the heart, so we're going to switch looking at the S and R waves with the different leads. So the very first thing you want to look for when you're looking for ventricular hypertrophy is to look and see if there's a right axis deviation. If you've got a right axis deviation, then be looking for that right ventricular hypertrophy. If you don't have a right axis deviation and you're looking for ventricular hypertrophy, then you need to automatically be looking for a left ventricular hypertrophy. So if somebody gives you an EKG and says, tell me which kind of hypertrophy does this person have, or if they even have it, you can tell them immediately, if you have a right axis deviation, well, I need to be looking for a right ventricular hypertrophy. And then you do the calculations. So this one, again, is kind of on the simple side, but it involves, instead of the S in V1, we're going to look at the R in V1. And instead of looking at the R in V5, we're going to look at the S. And those need to be 10 millimeters or bigger. So here we go. Again, let's look at AVR. AVR has a little bit of more of a positive deflection, but that could be because of the right ventricular hypertrophy, but we're going to go along with it. So the first question is there a right axis deviation? So looking up there at lead 1, we have a negative deflection, so my left index finger is pointing down. Looking at AVF, I have a positive deflection of that QRS complex, so my right finger is pointing up. Looking to see which fingers are going up, I only have one and it's on my right side, so yes, I have a right axis deviation. So now I need to look for the R in V1 and the S in V5. So here's my R in V1, and it's about 17 millimeters if we were to count it out. And then my S in V5, and when we count that out, it's approximately 20 millimeters. Just looking at V5 all by itself, I can tell that we have hypertrophy. So we're greater than 10 millimeters. So we know that we have a right axis deviation. We know we have the increased size. So yes, we can say we have a right ventricular hypertrophy. So let's try this one. First question I'm going to ask is, do I have a right axis deviation? Look at lead 1. Well, we're looking at AVR first, and again, it's got a positive deflection, but that may be related to a possible right ventricular hypertrophy. So lead 1 goes down, AVF goes up. So yes, we have a right ventricular, we have a right axis deviation, so we need to look for a right ventricular hypertrophy. So how many millimeters for the R in V1 and the S in V5? So let's look at V1 and let's see if we can count them up here. Let me get my pen out. So we're looking at the R wave. So we have, let's see, this would be a big block right there. And then the next big block is here. So we have 5, 6, 7, 8, 9, we could say. 9 boxes there. And then we come over here. Let's look at this one because it's unobstructed. So we start there, go up to here, and we can automatically say 5, 10, 15. So 15, and we're automatically over. So it's all greater than 10 millimeters. So we can go ahead and say we have a right ventricular hypertrophy. Let's look at this one. So first question to ask, do I have a right axis deviation? No, I don't have a right axis deviation. So I have the terminal forces in 1 going upward. I have the majority of the terminal forces in AVF going downward. So I actually have a left axis deviation. So let's look for a left ventricular hypertrophy. So how many in the S in V1, because this is the formula looking for left ventricular hypertrophy. So I'll let you count that up. So it's about 25 maybe, 5, 10, 15, 20. We'll say 20 there. And then let's go over to V5 and look at the R over there. And we have approximately 5, 10, 15. So if we say 15 and 20, that's 35. So it's greater than or equal to 35. And yes, it is. 20, 15. It's greater than or equal to 35. So we can say we have a left ventricular hypertrophy. So the next thing we want to talk about is, can anybody guess? Can anybody guess? Bundle branch blocks. I know, cute, isn't it? So when you get a right ventricular, let me try this again. When you get a bundle branch block, it usually indicates that one side is sending the signal down the bundle branch just a millimeter a second or so more than the other side is. So the right and the left depolarize in different speeds. So one is blocked, so one is going to polarize before the other one. So you basically get two QRS phases, and they don't mesh well together, and so you end up with kind of sometimes with maybe a widened QRS complex or rabbit ears or whatever. And this kind of just shows you what it is that you might see for a bundle branch block. But there are easier ways to tell, and of course I'm going to try and share them with you. So when you have a right bundle branch block, they call it RR prime. So the left side contracts before the right side does a little bit sooner. When you have a left bundle branch block, you kind of have a widened, kind of a slur at the top of the QRS complex. Again, RR prime. So when you have a right bundle branch block, and this is how I tend to look for it because it makes so much more sense to me in a lot of ways. So looking at our picture here, we can see that the right bundle branch is blocked a little bit. So we have to get our electricity from the left side of the bundle instead. And so it sends the signal over to the right side a little bit slower. But the big thing to look at when you're looking for a bundle branch block is to see in V1 which direction the QRS complex is going, whether it's going up or it's going down in V1. And then in lead 1, you look and see whether or not the QRS complex is wide or if it's skinny. Now I know what you're saying, but that's kind of a wide QRS complex. Not the first portion of it. It's kind of skinny, and you'll see the difference in just a couple of minutes when I show it to you. But we look at lead 1 and V6. They should look very similar to one another when we're looking at the bundle branch blocks. So notice how much thinner the QRS complex is, and that in the right bundle branch block, the terminal forces in V1 are going upward. So look in V1 and V2, you'll see that RR. Again, we're not going to worry about this because I'm going to show you again. In the left bundle branch block, look at V1 and notice that the terminal forces in V1 are going down. But look at the lateral leads for the QRS complex. Look at 1, AVL, V5, and V6. Now I just generally look at 1 and V6 because they should look very much alike. And actually it looks alike all the way through your lateral leads. So notice how wide that QRS complex is in compared to what it looked like in a right bundle branch block. So I look first for V1. Is it going up or is it going down? And then I look at lead 1 to see whether it's skinny or if it's fat. And then I again look at V6 to make sure it looks similar to V1. And again, this tells you a little bit kind of different story. If you understand it this way, this is great. But again, just kind of, if you follow my lead, it'll make more sense, I think. So, typical right bundle branch blocks. 3 leads to look at, like I just told you before. V1, lead 1, and V6. So V1, we will see an elevation or an upward deflection in V1. In lead 1 and V6, we should see kind of a skinnier QRS complex. And if you look at it and compared to what I showed you for the left bundle branch block, it is much skinnier. And then left bundle branch block again, V1, see if it's going up or down, and then lead 1 and V6. They're wider. They're much wider in the base. And so that's typical of a left bundle branch block. So when I'm looking to figure out which bundle branch block I have, I think about the steering wheel method. Now, there's this thing to the left side of our steering wheel that if you click up, it turns on this little light on the outside of your car and it blinks. And if you push up, it blinks the right little blinker. I know it's probably not something that you're familiar with driving on the streets, that you don't see too many people using it, but just go with me here a second. That same little lever on the left side of your steering wheel, if you push down, it makes the light out on the outside of your car, on the left side of your car, blink. It tells people you're going to turn left or you're going to turn right. So I like the steering wheel method because if you think about it here just a second, it kind of does the same thing. So I look at lead one, V1, I'm sorry, look at V1. Which way are my terminal forces going? Are they going up or are they going down? Okay. And then I look at my steering wheel and my signal. Is my steering wheel, when I click upward, I'm going to the right, and when I click downward, I'm going to the left. So if my terminal forces are going up, I have a right axis deviation, or a right bundle branch block. If my terminal forces are going down, then I have a left bundle branch block. So looking at V1, are they going up or are they going down? Is the QRS complex above the isoelectric line or below it? If it's above the isoelectric line, then I have a right bundle branch block. If it's below it, I have a left bundle branch block. All right, so let's try this one. So the first thing is, do we have a wide QRS complex in 1 and V6? And sure enough, when we look at 1 and V6, we have a widened QRS complex. We also have it in AVL and V5. So our lateral leads have wide QRS complexes. So when I see that, I have to think to myself, do I have a bundle branch block? And more than likely, if it's that wide, then I probably have a bundle branch block. So what's the next thing I look at? I look at the terminal forces in V1. Is it going up or is it going down? So if I got a wide QRS complex in 1 and V6, I need to be thinking left axis deviation. So I look at V1, my terminal forces are going down. In order for me to turn left in my car, I push the turn signal downward and I go left. So I have a left bundle branch block. Let's try this one. So I look at 1 in V6 and I notice that I don't have a wide QRS complex. So if somebody said, be looking to see if you have a bundle branch block. And so I look at 1 and V6 and I say, well, they're not wide QRS complexes by any means. And then I look at the terminal forces in V1, and what do I notice about the terminal forces in V1? They're positive. So if I have kind of a thin QRS complex in 1 and V6, but I have positive terminal forces in V1, I need to say that I have a right bundle branch block, because when I'm driving my car and I flip that little turn signal up, I'm signaling that I want to turn to the right. So if it's up, it's to the right. So we have a right bundle branch block. So do we have a wide QRS complex in 1 and V6? Yes, and we also have a wide complex in AVL and V5, which are also our lateral leads. So we need to think about a left bundle branch block. What are our terminal forces in V1? They're downward. To turn left, you push the signal down. So we have a left bundle branch block. It is just that easy. So if you have any questions, you can email me at the email address below here. I hope you enjoyed this lecture. I tried to make it as simple and easy as possible. Your task now is to get EKGs and look at them in a systematic fashion and think about all these different concepts that we talked about. It's just practice, practice, practice. Thank you for listening.